Good morning, everyone. Let's begin by establishing a clear clinical definition of sarcoidosis. Sarcoidosis is defined as a multisystem, chronic inflammatory disease. As the term multisystem suggests, it has the potential to affect various organs throughout the body over an extended period. Despite its clinical prevalence, it remains a disease of unknown etiology, meaning the specific underlying trigger has yet to be identified. The defining pathological feature is the formation of non-caseating granulomas. Unlike the caseating or necrotic centers we see in conditions like tuberculosis, these are solid, organized collections of inflammatory cells. While these granulomas can manifest in diverse tissues, they primarily target the respiratory system, specifically the lungs and the intrathoracic lymph nodes. Understanding this foundation, a systemic, granulomatous process of unknown origin, is crucial for our discussion today. Let's dive into the etiology and pathophysiology of sarcoidosis. While the precise trigger remains unknown, we understand it as an exaggerated Thiase-1-mediated immune response. This occurs when unidentified environmental antigens encounter a genetically susceptible host, specifically individuals carrying the HLA-DRB1 or HLA-DQB1 alleles. Mechanistically, this process is a classic type 4 hypersensitivity reaction. We see a significant accumulation of CD4 plus T lymphocytes and alveolar macrophages. These cells secrete pro-inflammatory cytokines, notably interleukin-2 and interferon gamma, which orchestrate the formation of our hallmark finding, the non-caseating granuloma. Finally, notice the unique biochemical activity within these granulomas. Macrophages express the enzyme 1-alpha hydroxylase, which independently converts 25-hydroxyvitamin D into its active form, 1,25-dihydroxyvitamin D. This autonomous, extrarenal production is the direct cause of the hypercalcemia and hypercalciuria we frequently observe in clinical practice. Moving to the clinical diagnosis, sarcoidosis is a true multisystem chameleon. On imaging, the hallmark is bilateral hilar lymphadenopathy, or BHL. Clinically, we look for painful shins, erythema nodosum, and the characteristic violaceous indurated facial lesions of lupus pernio. Ocular involvement often presents as acute anterior uveitis and blurred vision, while neurological signs may include unilateral or bilateral facial nerve palsy, known as Bell's palsy. From a respiratory perspective, patients typically report a dry cough and exertional dyspnea. Systemically, hypercalcemia can lead to symptoms like polyuria and polydipsia. On examination, you may also find parotid gland enlargement or hepatosplenomegaly. Finally, be vigilant for cardiac involvement, specifically cardiomyopathy manifesting as conduction blocks and arrhythmias. Recognizing this specific constellation of features across various organ systems is key to forming a clinical diagnosis. Now, let's focus on the scatting grading system, which is essential for classifying the radiographic severity of pulmonary sarcoidosis. This system is divided into 5 distinct stages based on chest X-ray findings. We start with stage 0, where the radiograph appears entirely normal despite the presence of systemic disease. Moving to stage 1, we identify the hallmark bilateral hilar lymphadenopathy, or BHL, occurring in isolation. In stage 2, the disease involves both the nodes and the lung tissue, presenting as BHL plus pulmonary infiltrates. As we reach stage 3, the lymphadenopathy has typically regressed, leaving only the pulmonary infiltrates behind. Finally, stage 4 represents the most advanced stage, characterized by progressive pulmonary fibrosis and permanent architectural damage. Understanding this progression, from nodal involvement to parenchymal disease and eventual scarring, is fundamental to your initial radiographic assessment of these patients. Moving on to investigations. Our first-line approach begins with a chest X-ray to identify bilateral hilar lymphadenopathy. Blood work should include serum ACE, a marker of active disease, alongside serum calcium, U and E's, and LFTS to screen for systemic involvement. The gold standard, however, is a tissue biopsy, often transbronchial or skin-based. Pathologically, we are looking for non-caseating granulomas, but remember, we must explicitly exclude other causes, such as tuberculosis. Supporting these findings, HRCT may show characteristic micronodules along bronchovascular bundles, while PFTS typically reveal a restrictive pattern with reduced DLCO. It is also vital to screen for cardiac involvement with an ECG to detect heart block or arrhythmias. Finally, we may utilize 24-hour urinary calcium or a gallium-67 scan, looking for the classic panda and lambda signs. This structured approach is essential for both confirming the diagnosis and assessing the extent of the disease. Management of sarcoidosis is highly tailored to disease severity and organ involvement. Many patients with stage 1 disease are asymptomatic and undergo spontaneous remission. For these individuals, simple observation is the standard approach. Treatment is indicated for symptomatic pulmonary disease, hypercalcemia, or vital organ involvement, specifically the eyes, heart, or nervous system. For acute symptoms like erythema nodosum in Lofgren syndrome, NSAIDs are our first-line choice. However, symptomatic stage 2 or 3 disease, hypercalcemia, and neuro or cardiac sarcoidosis require oral corticosteroids, typically starting at 20 to 40 milligrams of prednisolone. For refractory disease or steroid intolerance, we utilize steroid-sparing agents like methotrexate or azathioprine, reserving biologics like infliximab for severe cases. Finally, recognize these clinical emergencies. Symptomatic hypercalcemia requires urgent intravenous fluids and bisphosphonates. Acute uveitis needs immediate ophthalmic assessment. And cardiac sarcoidosis presenting with high-grade heart block or VT necessitates a pacemaker or ICD insertion. Let's focus on the high-yield MRCP pearls for sarcoidosis. First, you must distinguish between the key syndromes. Lofgren's syndrome presents with the classic triad of bilateral Hilar lymphadenopathy, erythema nodosum, and polyarthritis. It carries an excellent prognosis and rarely requires steroids. In contrast, Heerfordt's syndrome is a rare variant involving parotid enlargement, fever, uveitis, and facial nerve palsy. Moving to biochemistry, remember that hypercalcemia is driven by 1-alpha hydroxylase activity within granuloma macrophages. When ordering a serum ACE, remember it reflects total body granuloma burden and is used for monitoring disease activity, not for the initial diagnosis. Regarding skin signs, lupus pernio is the most specific manifestation and often predicts a chronic persistent disease course. Finally, on pulmonary function tests. Sarcoidosis typically presents with a CHUK restrictive pattern and a reduction in the transfer factor, or DLCO. These specific associations are frequent exam targets, and that brings us to the end of today's session. I hope this has been a valuable and clear overview. To truly consolidate this knowledge, I encourage you to take the next step. Visit our online platform at mrcpelite.com. There, you can create a free account instantly. You will find a structured slideshow summarizing today's topic, followed by 2 dedicated self-assessment tests, one for MRCP Part 1 and another for MRCP Part 2, each containing 20 focused questions. Take these tests to actively engage with the material. The platform will provide you with an immediate score and, most importantly, detailed, illustrated explanations for every answer, helping you fix the information firmly in your mind. To supercharge your preparation, consider upgrading to a pro user subscription. This unlocks powerful tools, unlimited disease-specific search queries, unlimited access to high-yield exam pearls, unlimited interactive flashcards, and most critically for your exam readiness, full exam board access with 50 question banks for every MRCP subject, and realistic mock exam simulations for both Paper 1 and Paper 2 that closely mirror the actual exam environment. For a limited time, we are running an exclusive offer. Gain all these pro benefits for just $50 for a full year. a significant saving from the standard price of $250. So, head to MRCPELITE.com now. Start with your free account, test yourself, and explore how the Pro upgrade can transform your revision journey. Thank you for your time and all the very best for your studies.